is a patient with vascular dementia, a real living patient, here with her caregiver. If we were to develop an hypothetical treatment for this patient, again, there is acetylcholine deficit, we know what to do. There is serotonin deficit, we know what to do. A norepinephrine deficit and hypermetabolism, we know what to do. And then, especially in patients with rapid decline, we want to consider the use of glutamate. Lewy body dementia. Lewy body dementia is much more prevalent in Jamaica than we realize. In fact, this is the dementia that is most commonly identified in misdiagnosis when we do brain bank studies. A significant number of our patients who we think have Alzheimer's disease are actually suffering from Lewy body dementia. How do we make the distinction? It is very similar to Alzheimer's disease. The dementia portion of Lewy body dementia is similar to Alzheimer's disease. Yes, it tends to start a little earlier. Yes, it tends to progress a little faster. There tend to be fluctuation in their cognitive status from day to day, from hour to hour, but also from minute to minute. These patients may be confused as epilepsy patients because they may just sit and stare in space for a while. And you wonder what's happening. I have a particular patient who ended up doing about 4 MRIs because we were sure that he was having a TIA. He blocks out. You do your MRI, nothing shows up. A month later, he blocks out again. You're sure he's having a TIA. You do an MRI and nothing. They tend to have periods of confusion. Men tend to be affected more. In fact, in making the diagnosis of Lewy body dementia, we will see signs of dementia that is similar to that of Alzheimer's disease. However, their mental status fluctuates from day to day and from hour to hour. They tend to have signs of Parkinsonism. Yes, they have rigidity, bradykinesia, but they tend not to have tremor. And they have very vivid visual hallucinations. The hallucinations are very interesting because they may not mention them to you because they're not nice. They are seeing people. In Jamaica, what I find is that they see a lot of dead people. The hallucinations do not disturb the patients, and that is why they don't necessarily mention it to you. They know that they're not supposed to be seeing these people. They know that these people are dead. One male patient I have, he sees children. What upsets him is not that the kids are there making noise, but that they should have gone home by now. One man saw some thieves passing through his house with M16 guns. So I asked him, what did you do? I don't do anything. They didn't trouble me, so I don't trouble them. The hallucination does not bother them. They don't want to see it. And if you show that you understand what is happening, they will tell you what is going on. This is not a very difficult diagnosis to make. Yes, they have the visual hallucination. They have delusions and other signs also. They tend to be sensitive to neuroleptics. 50% of them, when given neuroleptics, will not survive. So we want to make this diagnosis before we start treating them. They tend to have autonomic dysfunction. They will sweat a lot. They will sweat a lot. They will have constipation. They will block out. They will fall. These patients tend to lose their protective reflex. So if they're walking and you buck a toe on a chair, we tend to catch up. That's our protective reflex. They cannot do that. They go straight down on the ground. So they fall regularly. They tend to have REM sleep behavior disorders. They have problems sleeping. They walk, they talk, and they fight in their sleep. They act out their dreams. So, and this has happened to me personally. I've dreamt that I'm fighting, and my wife woke up with blows all over her body. So they tend to do that on a regular basis. But in the morning, they will tell you that I had a fight last night. I had a patient an American citizen, who said that she's in a nursing home in Jamaica. The robbers came in her room in the night, thumped her off the bed, right? And then they left. So she called the American embassy that robbers came in her room. They called me from the nursing home that the American embassy staff came in with their security people and with local police to get this woman out. So we're taking her back to America because she's been abused. She dreamt that she was being attacked and she fell off. She did fall off the bed. The door was locked, the windows were locked. There's no way anyone could have gotten inside. That is lower body dementia for you. So what do we know about neurochemical changes in lower body dementia? Acetylcholine deficit is even greater than in Alzheimer's disease. There is no serotonin deficit. Yes, there is a dopamine deficit, which tends to be greater than in Alzheimer's disease, which is why they have the bradykinesia and rigidity and so on. So, if we were to develop an hypothetical treatment for these patients, clearly Palixid, Aricept, Reminil, and Exelon would be a part of the treatment. What about the Parkinsonism? Increasing the dopamine levels in these patients may increase the visual hallucination and other forms of hallucination. So most physicians would be very careful and try not to use agents to improve the dopamine levels. There is no serotonin deficit, so there's really no need for SSRIs. You want to be very careful what you use for their sleep disorder, because not just neuroleptics, but many other sleeping medications can trigger off this type of hypersensitivity reaction, almost like a neuroleptic malignant syndrome. How do you manage the psychosis? Does it bother you? No, but I don't want it to happen. In most cases, the psychosis bothers the family members. So we give them antipsychotics, which can cause problems because of the family members. In my practice, I tend to try benign neglect. If you explain to them about why you're having the hallucination, it's not a major problem. Many times they are able to live with it. So you can avoid using a neuroleptic. If you must, we find that Seroquel is one of the safer ones to use. Again, glutamate is a major factor in severe cases, so memantine may have some purpose in this type of dementia. Finally, I'm going to say a few words on frontotemporal dementia. This is a type of dementia. This is the most common type of dementia that you will see in patients in their late 50s and early 60s. There are three clinical anatomical types: frontotemporal, primary progressive aphasia, and semantic aphasia. These patients may not have severe memory impairment. This group, they will tend to have disinhibition because of involvement of the frontal lobe. The primary progressive aphasia patients, they talk less, they are less motivated, they become mute. This is primarily because of involvement of the left anterior temporal lobe. And the semantic aphasic patients, they speak fluently. I have a patient who's the mother of a very prominent doctor. When she comes to me, she speaks, she never stops speaking. The words are not connected. There's no meaning. In fact, this is sometimes called fluent aphasia. Her problem is that she will not be able to identify a pen or a dog or a chair. She speaks fluently, but there's absolutely no connection between the words. What do we know about this type of dementia? There's no cholinergic deficit. There is a serotonin deficit, and GABA and glutamate is also in deficit. So in developing a treatment modality, we need to take that in consideration. Uh, so there's no need for cholinesterase inhibitors. Serotonin is down, so we may need SSRIs. Dopamine may help us to improve their function. GABA and glutamate may also be considered in these patients. Uh, can I be given 2 minutes extra? Thank you. There is a type of dementia that we are now coming across called subcortical dementia. These patients are usually patients with high blood pressure, diabetes, high cholesterol. They do not present with memory impairment so much as they present with emotional impairment. These are our mothers and our fathers who are now difficult to get along with. They make mistakes at home. They will leave the stove on, and you ask them about it, and they'll say, I didn't leave the stove on. So we say that their mom has started to lie, and so on. It's very difficult case to deal with. And this occurs because of minute strokes primarily in the subcortical areas. I mentioned earlier that we have the connections between the subcortical area and the frontal lobes. A small stroke in the subcortical white matter can actually disturb the connection between the frontal cortex and the striatum and other subcortical areas and give you a clinical picture as if you had a stroke in the cortex. There are 5 types of these frontal subcortical syndromes. 3 of them are of clinical importance. Depending on the area of the frontal lobe that is involved, if the dorsolateral part of the frontal lobe is involved, the patient is going to give you impairment of executive function. They cannot plan and execute normal activities. If it occurs in the orbitofrontal area connections, then what you have is that they lose social intelligence. These are the ones who will become disinhibited and become familiar, undue familiarity. And if it's in the anterior cingulate, you get motivational issues. Here we have the dorsolateral prefrontal circuits being involved. These patients are going to have impairment in executive function, loss of behavioral plasticity, utilizational behavior. My mother had that problem. If you put out a chicken she cooks a chicken, she's going to eat the entire chicken. They'll have things on the table, she's going to use everything. If the things are there, they will touch it and they will use it. So they have impairment of executive function, which means that they cannot function independently. The anterior cingulate controls the motivation and drive. So these patients where this circuit is impaired will lack motivation. They will lack motivation. They may develop akinetic mutism where they just don't do anything, they don't talk, mental slowing in, and so on and so forth. And then those with the lateral orbitofrontal circuits, these are the ones who don't worry about anything. They will be the typical Jamaican, no problem. They will petty crimes. These are the ladies who are multimillionaires and they continue to shoplift, and we know about them. They are usually having a type of dementia without impairment of memory.